Hi everyone, my name is Amit Mishra, and the topic we're going to be exploring today is 3,4-methylene dioxymethamphetamine, also known as MDMA, ecstasy, E, or Molly. We're going to dive into its history, pharmacokinetics, pharmacodynamics, its effects, how it relates to addiction, as well as how it can be used for therapeutic purposes. Let's talk a little bit about the history behind MDMA. It was first discovered in 1912 by a German pharmaceutical company called Merck, who was developing an appetite-suppressing drug while avoiding a chemical reaction pathway which had been patented by another company. Around the 1980s, the recreational effects of MDMA were understood and it gained popularity as a party drug. The drug was sold around parties, raves, nightclubs, and festivals because it produced euphoric feelings as well as sensitivity to light and sound, which worked together well with the party environment. In 1985, the DEA banned MDMA and classified it as a Schedule I controlled substance because of its high risk of abuse and lack of clinical uses. Between the 1990s and 2000s, MDMA continued to be sold illicitly and sales peaked between this period, with instances of usage decreasing thereafter because of DEA restrictions. It is still illegally available on the streets as a party-safe drug, most commonly sold as tablets or capsules, sometimes powder. Though the pharmacokinetics of MDMA is not fully researched, there is a lot that is known about the drug's activity in the body. As it is most commonly found as tablets or capsules, the drug is orally administered. After traveling to the stomach, the capsular layer or the tablet filler is shed so that the MDMA can move to the small intestine where it's absorbed by the microvilli. It is then distributed by the body through peripheral circulation, where it reaches the brain. After activity in the brain, it reaches the liver by peripheral circulation once again to be metabolized. In the liver, a group of enzymes called the cytochrome 450s and catechol-methyltransferase, denoted as CYP prefix and COMT in the diagram, break down the MDMA into metabolites. The same enzymes can take two different metabolic pathways depending on the drug or enzyme availability. The metabolic process for both pathways involve methylation and demethylation. Both pathways are the same except that pathway 2, on the right here, has a preceding demethylation step, where the demethylation occurs at the end in pathway 1. After the metabolites HHMA, HMMA, HHA, and HMA are produced in the liver by this pathway, they are conjugated by sulfate or glucuronic acid before traveling to the kidneys for urinary excretion. MDMA is known to act as an indirect agonist of serotonergic pathways, but it also affects dopaminergic and adrenergic neurons because of its similarity to serotonin, dopamine, and norepinephrine. The drug acts as a reuptake inhibitor. After it enters the brain, MDMA travels from the synaptic cleft into the presynaptic neuron, disrupting the activity of vesicular proteins. As a result, the serotonin in the presynaptic neuron is released from vesicles into the cleft and can't re-enter the presynaptic neuron, causing accumulation in the cleft. The MDMA also attaches to the serotonin membrane transport protein, causing it to reverse its function. This means that instead of bringing serotonin in, it moves serotonin out. Because it acts as a reuptake inhibitor, the serotonin stays in the cleft instead of re-entering the receptor. The buildup of serotonin in the synaptic cleft is what causes the associated positive feelings such as euphoria. This mechanism applies similarly to dopamine and norepinephrine neurons as well. MDMA is classified as an empathogen or an entactogen, which essentially means that it causes feelings of compassion, empathy, and closeness in users. Most of the physiological responses are due to the stimulated release of these three neurotransmitters. Because MDMA primarily affects serotonin, many of the effects can be associated with pain, sleep, appetite, and mood. MDMA is also slightly hallucinogenic, causing visual hallucinations in 20% of users, but rarely any audio hallucinations. Some of the short-term effects following immediate use are audiovisual sensitivity, alertness, elevated mood, or more intensely, euphoria, enhanced emotionality, decreased social inhibitions, and dyschronometria, which is the warped perception of time. Because MDMA stimulates adrenergic pathways, it is stimulative. As a result, users may take it to defeat tiredness and keep partying. In addition to inhibiting thermoregulation, exercise can cause overheating and dehydration, possibly leading to tissue damage. Because the use of MDMA depletes the serotonin, dopamine, and norepinephrine, users will often see an ecstasy crash after use. This crash can last for days to weeks while the chemicals in the brain replenish. During this time, little dopamine is available to activate reward pathways, so users are left feeling depressed, unenergetic, fatigued, and irritated. They may commonly experience headaches and malaise. Depletion of serotonin is also known to cause confusion, short-term memory loss, and anxiety. The effects of long-term use are somewhat more damaging. With chronic use, individuals could see permanent damage to serotonin receptor pathways as a result of MDMA's pharmacokinetic effects. A study showed that chronic use for 6 months could decrease the number of 5-HT receptors in the brain. This changed the metabolism of cerebral glucose, which caused further developmental changes of the hippocampus and amygdala. Another study in rodents showed permanent receptor damage after only 4 days of use. As such, long-term effects can include cognitive disruptions, deterioration of verbal memory and reasoning, impaired ability to recognize speech, weakened formation of visual memories, generally decreased intellect, with some users also reporting episodes of psychosis. MDMA is not a highly addictive substance as it primarily activates serotonergic pathways over dopamine reward systems, causing less intense positive feelings. However, it is still possible to build a tolerance to the drug with chronic use. MDMA is classified as a party drug among pop culture and is therefore distributed as ecstasy, in which MDMA is the primary psychoactive component, in clubs, raves, parties, etc. It is often mixed with other drugs in order to increase its addictive potential. Therefore, the demographics such as college students and older adolescents are at higher risk for use. As a result of both the less reinforcing positive feelings and the significant negative effects of the ecstasy crash, MDMA is far less addictive than other drugs such as cocaine or methamphetamine. Though it is circumstantial, chronic use could lead to physical dependence. However, this would not manifest in physical withdrawal symptoms after use is halted. Any reported withdrawal is likely psychological. Ceasing use could lead to psychological distress, causing users to continue administration in hopes of reducing the effects of the ecstasy crash in order to cope. There are few treatment strategies for MDMA addiction due to lack of physical withdrawal symptoms. For psychological distress as a result of cessation, inpatient programs at hospitals or rehabilitation centers are highly recommended because they provide safe, monitored, controlled environments which minimize the risk of relapse. An individualized course of treatment is developed based on external circumstances. An individual's distress symptoms such as anxiety, irritability, paranoia decrease in severity over the recovery period, and the patients may be prescribed medication to help with depression and other effects of the ecstasy crash. Outpatient programs are also available but are reported to be far less successful. Cognitive behavioral therapy such as counseling, talking to a therapist, or participating in support groups is highly effective in such successful treatments, especially in the case of psychological comorbidities such as depression, anxiety, schizophrenia, bipolar disorder, etc. Can MDMA be helpful to patients with psychological disorders? Early studies in the 80s showed that MDMA could potentially be beneficial in treating mental disorders, especially in those with post-traumatic stress disorder. Small doses of MDMA were administered as an empathogen alongside psychotherapy to decrease a patient's fear, allowing them to feel more empathetic and open, developing trust toward their therapist, and helping them process their traumatic memories. A 2013 longitudinal study by Mathofer revealed that 83% of patients with PTSD recovered during psychotherapy treatments alongside MDMA co-administration in comparison to their placebo counterparts. The FDA is currently reviewing the potential for MDMA use in similar clinical treatments if proven efficient by late 2021. Other studies have explored MDMA co-therapy to treat alcohol use disorders as well as autism-associated anxiety. However, the results are still inconclusive. With these forms of assisted therapy, there are some considerable limitations. For example, an increased MDMA production or accessibility could lead to misuse or abuse of the drug if there were a flaw in the distribution network throughout the hospitals or rehabilitation centers. Additionally, if it were to be misused, the negative effects could be highly counterproductive to the assisted psychotherapy, far outweighing the benefits of the successful treatments. As such, the treatments would need to be limited to only take place in highly controlled environments, with supervision being a top priority. Lastly, MDMA use for patients with other psychological comorbidities is yet to be conclusively understood, so there is a need for more research before widespread use can be implemented. MDMA evidently has the potential for successful clinical co-therapies around PTSD, and could even prove useful for other disorders in the future. However, the drug still possesses some shortcomings such as its risk of abuse and negative effects, which sets back research due to restrictions, justifiably so. There is further research needed in order to provide a well-reasoned framework of appropriate commercial use of the drug. Future research experiments to further our understanding could include exploring its effects in individuals with psychological comorbidities, a developing correlation between the drug's short-term effects and different demographic populations, or even the effect of chronic MDMA use on long-term behavior. Research about this drug could be further accelerated if DEA-sanctioned restrictions on MDMA were lifted. Not only is the accessibility and authorizations to research MDMA in clinical settings difficult to acquire, a study showed that street ecstasy has up to 250% variation in MDMA concentration, whereas labs produce unadulterated versions. This could produce significant errors in results from lab studies to real-world observations. A solution could be the provision of DEA-seized street ecstasy to labs for studies and research. Seeing that MDMA is ultimately destroyed by the DEA after being held for evidence, it would be productive to sell or distribute the confiscated drugs to labs for study. However, the process would understandably need to be thoroughly monitored in order to ensure that the ecstasy is not stolen or misused. Thank you for watching.